Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching video casts. These are meant mainly for undergraduate medical students doing their surgical clerkship rotation. But these operative surgery videos are mainly meant for postgraduate students or the surgical trainees. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. So, in this episode today, I am going to discuss one more operative surgery video that is on lap abdominoperineal resection or lap APR. So, what are the indications for lap abdominoperineal resection? It is the low rectal carcinoma where adequate clearance cannot be obtained by the anterior resection. This is number one indication. Number two, inflammatory bowel diseases like very severe Crohn's disease with multiple fistulae. Number three, as part of the procedure of total proctocolectomy. Number four, for APR, laparoscopic technique is preferable as it eliminates all major abdominal incisions. And then the lap APR is contraindicated if the tumor is bulky, that is T4 tumor, or if the patient is having very narrow pelvis. So I told you already the indications. It is carcinoma in the lowest part of the rectum, IBD, that is especially severe Crohn's with multiple fistulae, and as part of total proctocolectomy. Contraindication, big tumors, that is T4 tumors, and those patients who are having very narrow pelvis. Of course, anesthesia, we have to give general anesthesia with endotracheal tube intubation. Position is modified Lloyd Davis lithotomy position with padded Allen stirrups. Diagnosis should be confirmed by doing a colonoscopy and taking a biopsy, and staging must be done by contrast enhanced CT. The pre-op preparation, pre-op chemoradiation treatment is indicated for patients with T3 and T4 lesions or tumors with enlarged pelvic lymph nodes found on pelvic computed tomography scan or endorectal ultrasound. Adequate mechanical bowel preparation even the day before surgery with orthograde enema must be done. Prophylactic IV broad spectrum antibiotics should be given. VTE, that is venous thromboembolic prophylaxis with low molecular weight heparin, or we can use pneumatic stockings to prevent venous thromboembolism. Bladder should be catheterized with Foley catheter. The stoma nurse marks the permanent colostomy site in the left iliac fossa with the patient in sitting posture. They have to mark it preoperatively. Yes. The intraoperatively rigid proctoscopy should be performed to determine the distal end of the cancer. So this is the surgical anatomy. So our surgical procedure is AP resection. So we have to know about the inferior mesenteric artery, which is supplying the sigmoid colon, rectum and anal canal. So this is main branch of inferior mesenteric artery from aorta. After taking off, this will give the left colic artery, which should be spared in this surgery. After this left colic artery branches out, then okay, we can ligate at this level so that all the sigmoidal arteries, these are the sigmoidal arteries, and the superior hemorrhoidal artery will be blocked or will be cut off. This is what we have to know, and we have to remove only up to maybe the middle of the sigmoid colon. At the, up to this level only, okay, we have to remove the colon. Okay, so we have to mobilize or we have to make a small hole in the mesentery, and then we can use a GIA stapler to divide this. But we have to do it not, this is not an open surgery, so we can use a laparoscopic GIA stapler to divide this. This we have to do. Okay, I will be explaining all these things step by step. So the first thing is the position of the patient. I've already told you it is the modified Lloyd-Davis lithotomy position with padded Allen stirrups. This is what you are seeing in this picture. This is this modified Lloyd-Davis lithotomy position. Surgeon should stand on the right side, the assistant on the left side. Secure both chest and head to the table with foam and tape. This is what you are seeing. This is the foam and this is the tape with which you have to secure both the chest as well as the head to the table. And the foot end also, okay, this is the Allen stirrups. And then what is the port placement? 10 mm camera port just above the umbilicus. So here. And then 3 5 mm trocars at left lower quadrant, and then right upper quadrant here, and then in the suprapubic region. In the right iliac fossa region, we can use 12 millimeter trocar site for introducing the laparoscopic GIA stapler. Okay, the optional fourth 5 mm trocar at left upper quadrant if you want to mobilize the left colon very well. That also it is optional. Exposure, the table may be tilted to the right side with Trendelenburg position so that all the small bowel from the pelvis will fall off from that area. Surgeons should stand on the right side. The small bowel should swept out of the pelvis to right upper quadrant, and then any adhesion between small bowel and sigmoid colon or lies if there are any adhesions. Okay. Then assess the position and resectability of the tumor. We have to assess the liver and peritoneum for metastatic deposits and the whole colon for synchronous tumors. After retracting the sigmoid colon towards the left anterior suprailiac spine, this is the thing. You have to hold it and you have to retract it towards the left anterior suprailiac spine. We have to make an incision in the peritoneum over the sacral promontory. This is the incision. And dissect the retroperitoneal area. You have to dissect in between the mesorectum and the retroperitoneal area here. And while you are doing this resection, you have to avoid injury to the left ureter and left gonadal vessels. This is the left ureter, this is the left gonadal vessels. So this injury also you should avoid. The next step is ligation of blood vessels. We have to elevate the sigmoid colon and isolate the inferior mesenteric artery and left colic artery, which should be spared if appropriate. That means the left colic artery should be spared. Ligate the superior hemorrhoidal artery at its takeoff from the inferior mesenteric artery, and sigmoidal arteries also should be ligated. So here you are seeing the this is the inferior mesenteric artery, and you have to ligate after it is giving the left colic branch. After that only you have to ligate both the mesenteric arteries as well as the superior hemorrhoidal artery. We have to ligate and then we have to transect these blood vessels. Spare the left colic artery. While doing this procedure, again you should avoid injury to the left ureter and left gonadal vessels. The next thing is mobilization of left colon, the next step. So now you have to incise the white line of Tolt, that is the lateral embryological line of fusion. You have to make an incision and you have to extend the incision up to the splenic flexure. Mobilize the left colon from retroperitoneal structures for tension-free end colostomy creation. The purpose of mobilization is just to create a tension-free end colostomy. Again, during this maneuver, we have to avoid injury to the left ureter and left gonadal vessels. And this mobilization is known as Mattox maneuver or medial visceral mobilization or medial rotation of the viscera. The next step of surgery is anterior rectal resection. Put the patient in Trendelenburg position. Surgeon should now stand on the left side. Extend the lateral facial incision we made over the white line of fusion, that is the line of Tolt, up to the upper rectum. So we have to extend this one. See here, you have to extend this incision up to the upper rectum. And then the peritoneum is incised medial to the right ureter here in the right side. Okay, medial to the right ureter and extend around the rectum. You have to go around the rectum here. Okay, to join the pelvic peritoneal incision which we made on the left side, that is meeting anterior. So both the incision, both the left or lateral incision and the medial incision, both should meet in front of the rectum here. In females, dissect through the rectovaginal septum and in males through rectovesical space. See here you are seeing a female pelvis. If you are doing it, okay, you can even anchor the uterus with a stitch to the anterior abdominal wall, okay, so that you can retract it. And for in a female patient, you can also use a EEA sizes both in rectum and vagina in females that help to define the space, that is the rectovaginal spectrum. You can make out very well by putting these EEA sizes both in the vagina as well as in the rectum. In male patient, this dissection should be ventral to the denon-villus fascia here to spare the seminal vesicles. So we have to do like this. This is the anterior rectal dissection. So now the posterior, next step is the posterior rectal resection. Carry on the dissection in the avascular plane between the mesorectum and the presacral fascia posteriorly. For that, you have to hold the sigmoid colon like this. Okay, you have to hold it in the upper part. Then you can see the posterior part of the rectum. Okay, the mesorectum is mobilized laterally here. You have to mobilize laterally toward both the right and left pelvic side wall, preserving the hypogastric nerves and ureters on the sacrum. Here you can see both, this is the right ureter. So you have to mobilize the mesorectum to the pelvic wall on both sides, where you can see the right ureter and right hypogastric nerve. This is the right hypogastric nerve. Both these structures should be preserved. Then, okay, you can also ligate this lateral ligament. Anterolateral ligament with middle rectal artery is now ligated here. carry the dissection through Waldeus fascia. Waldeus fascia, this is the Waldeus fascia is connecting the mesorectum with the presacral fascia. So you have to go dissect through the Waldeus fascia up to the level of pelvic floor at levator ani level. So this is the Waldeus fascia. You have to cut it and then you have to dissect up to the pelvic floor where there are levator ani. Up to that, not just coccyx alone, because this is APR procedure. So you have to go up to the pelvic floor or sorry, the level of levator ani. Up to that you have to dissect. The next step in the surgery is creation of end colostomy. The colon is brought up to the anterior abdominal wall. I mean, the divided colon is brought up to the anterior abdominal wall at the previously marked left lower quadrant colostomy site. Ensure that the proximal colon will reach the site without any tension. If there is concern about sufficient length, the splenic flexor also can be mobilized at this stage. Point on the colon to create the colostomy is identified and the mesentery is divided to this point using a vessel sealing device like harmonic scalpel or ligature. An endo-GIA stapler is introduced through the right lower quadrant port and the colon is divided. This is the endo-GIA stapler. This should be introduced through the right lower quadrant port and you go and divide the selected site of the either the descending colon and sigmoid colon junction or even in the mid sigmoid you can divide it. The proximal stapled end of the colon is grasped with a ratcheted grasper. This is here, this is the ratcheted grasper, and the disc of skin is excised. You have to refine the disc of, this is the disc of the skin, okay, excised at previously marked soma site. Then inside the rectus abdominis muscle also, because the colostomy site, the colostomy should come through the rectus muscle, not lateral or medial to rectus muscle. The proximal colon, correctly oriented, is passed from the laparoscopic grasper to the handheld Babcock's clamp inserted through the stomal incision. So here, this is the Babcock clamp, this is the ratchet, laparoscopic ratchet. So it should be brought through the colostomy site, created through the rectus abdominis muscle. So the proximal colon should be brought out here. Trim the stapled end and then fix the colon circumferentially to the fascia to begin with, and then the end of the colon to the skin with both with absorbable sutures. So after this, we have to divide this stapled end and then suture circumferentially to the fascia here, deeper and deeper side in the superficial area of the colon, where this is already the stapled end is trimmed. So you have to suture this end to the skin. So all trochus are removed now and the umbilical incision fascia is also closed. The next step in the operation is perineal dissection. Now you have to close the anal orifice with 0 or number 1 silk pursing suture. Yeah, this is what you are seeing here in these two pictures. An elliptical incision is made around the anus midway between the ischial tuberosities and the external anal sphincters. Circumferential dissection is carried down through the ischiorectal fat outside the anal sphincter. So you have to incise it deeply. The anococcygeal ligament posteriorly is divided just anterior to the coccyx, and the peritoneal cavity is entered between the rectum and the coccyx posteriorly here. Now, the levatas are identified and looped with an index finger. This is what you are seeing in this picture. So here you have to put your index finger inside. This is the levator muscle. Okay. And you have to divide them with electrocautery. Working anteriorly from posterior, you have to divide this levator anteriorly towards the prostate in male patient and towards the vagina in the female patient. The anterior dissection is completed by dissecting whatever adhesion is there between the prostate and the rectum in a male patient or the vagina and rectum in a female patient. So these adhesions, you can put a finger behind and you can cut it with electrocautery. So now we have to remove the perineal specimen. This should be, see, until now this is the staple end of the distal colon. So tumor is somewhere here in the lower part. Now we have detached the whole thing. Now you can remove it through the perineal wound, delivering the sigmoid colon and rectum through the perineal defect created by the division of anococcygeal ligament and the levatas must be done at this stage. Then finally the perineal wound closure. Hemostasis within the pelvic cavity should be confirmed. The pelvis is then copiously irrigated through the perineal defect. If sufficient levator muscle exists, the pelvic floor is closed with interrupted absorbable suture from the coccyx to the anterior sling. The subcutaneous tissue is reapproximated. You are seeing it here in layers using again interrupted absorbable suture. The skin is closed with running absorbable suture. This is what you have to do. So what are the complications of lap abdominoperineal resection? It could be paralytic ileus, wound infection, bleeding, urinary or sexual dysfunction, colostomy related complications, or laparoscopy related complications. So what are the post-op care you have to take? There is no need to continue antibiotics post-operatively unless there is intra-abdominal infection. Ambulation and incentive spirometry on post-op day 1 is important for prevention of post-operative atelectasis. Clear liquids are started on post-op day 1 itself, and diet is advanced as tolerated. The Foley catheter is left in place for few days because of high incidence of urinary retention in male patients. DVT prophylaxis should be continued until the time of discharge and can be considered as an outpatient in certain subsets of patients who are more prone to develop venous thromboembolism. So thank you very much for watching this video. If you think that these videos are very useful, kindly subscribe to this channel and share these videos in your social media. Kindly click the bell button also to get notified regarding my latest video uploads. Thank you once again for watching this video. Let us meet in yet another episode. Until then, bye bye.